We're here to talk about the TIMI risk score for stable ischemic heart disease, which was derived in a clinical trial called TRA2P TIMI 50. Several years ago, TIMI derived a risk score in patients with acute coronary syndrome. What's new now is that we are developing a risk score. We will be presenting, actually Dr. Bahula will be presenting a risk score to predict long-term risk in stable outpatients that have known coronary disease, specifically a history of myocardial infarction. And it's particularly relevant now because there are now 3 trials which show that there is ischemic efficacy for various agents. There's TRA2P TIMI 50, DAPT, and Pegasus. But clinicians really need to know who are the patients that derive the greatest benefit, because there is a trade-off with bleeding. Dr. Bahula and Dr. Morrow led this effort, and they looked at risk factors that predicted ischemic risk. And I think it's important that there are many factors one could look at, but they made a particular effort to select factors that are clinically obvious, that are practically knowable, so it'd be easy to apply this in practice. So clinicians that are used to the CHADS score, the CHADS-VAS score, will find it very familiar because a lot of the same elements are there. It does not contain angiographic elements or novel biomarkers that you might not have access to in the clinic, so it's a practical score to predict risk. I think the concept is very similar, that you have an ongoing disease state like AFib. CHADS lets you know who's at the highest risk. This score is for a different disease state. So CHADS wouldn't help for post-MI secondary prevention, but like CHADS, this score will help clinicians understand this is a patient who's going to be at heightened future risk. So the kinds of factors included in the score are ones that I think people intuitively know are associated with heightened risk. So diabetes, age, renal dysfunction, disease in other vascular territories, but it puts them together in a way that allows them to easily in their mind calculate by an integer system what is the future risk of an atherothrombotic event. And I think one thing that's important that distinguishes this score from some other scores, both in long-term DAPT after PCI or atrial fibrillation, is that the outcome is, I think, a broad ischemic outcome that's relevant for long-term therapies. It includes cardiovascular death, ischemic stroke, and myocardial infarction. That's part of the problem with secondary prevention. If you're having a myocardial infarction, everybody knows what's going on, you apply your most intensive therapy. The whole concept of secondary prevention is that you want to prevent that event from ever happening. And so you can't apply these very potent therapies across the entire population because there are risks too. And that's why you need a way to identify who are those at the highest risk that are more likely to derive benefit. And even though therapies may work broadly so that the relative risk reduction is the same across a broad population of patients, when you find individuals that are at heightened risk, for example diabetics, by nature of their higher risk, they derive a greater absolute benefit from therapies. I think this and other scores will have a profound impact in how cardiologists and general practitioners practice going forward. And the reason why is that now there are 2 therapies at least. There's ticagrelor and vorapaxar, which have indications for long-term secondary prevention. Both drugs cause bleeding, and our guidelines and the most recent ESC guidelines say you need to think about ischemic and bleeding risk, yet there are no tools to do so. Earlier today we heard about the DAPT risk score, which is one after stenting based on some angiographic features and clinical features. I think that's an important step forward. This score is a broader score. It's somewhat different in terms of all patients that are post-MI, but I think these are the kind of tools that are going to become routine in clinical practice in the future, similar to the way CHADS and CHADS-2-VASc are in atrial fibrillation. There absolutely is a risk, and I think there's a risk that there will be many scores put out and people won't know which one to reach for. And so I think that it is important that as a scientific community we come together and we validate across our different data sets. We work together to develop really a score or a group of scores that there's some consensus around that these are the ones that you should use. And I think that while it's always great to have something on your iPhone or a web-based calculator or a fancy new biomarker, in practice, for most of us that see patients and we have 15 minutes to see them, we need something that comes to mind quickly. I know you have diabetes, I know you have hypertension, I know that you need this therapy, and I think there needs to be some work towards making these scores very practical for clinical use. In the age of iPhones and computers, a lot of times we spend time looking at the computer and not the patient in the clinic. But a fundamental issue here is, how do we communicate to patients that they have risk? You know, when you prevent a heart attack, nobody knows, right? When you cause a bleeding event, people are very aware of it. And so there is a very sensitive interplay here in that interchange between a physician and a patient when you're trying to prevent something bad from happening that they don't feel. You know, how do you communicate and how do you face the patient and talk about it? And I think too many calculators, too many tests can distract us from that really important task. We are an aging population. There is increasing obesity and increasing diabetes. So I think that we can clearly say is that ischemic risk is increasing along with the population, that the need for long-term secondary prevention is not going away. If anything, the need is increasing. But it is complicated because some of those things that you talked about, age, for example, it's very closely associated with ischemic risk and bleeding risk. And so how do we figure out which therapies are best for an individual patient? And that's where I think these tools are really critical, so that you can individualize therapy to a particular patient depending on their risk factors. Dr. Bahula and Dr. Morrow developed a score in one data set called TRA2P TIMI 50. And with this score, they're able to predict ischemic risk. And importantly, they show a gradient of benefit in terms of the magnitude of benefit with therapy, a PAR1 antagonist called Vorapaxar, where the net benefit looks increasingly better as you step up in risk. I think steps forward from here are to validate the score in other data sets and to look at other therapies. Other therapies, instead of only a PAR1 antagonist, let's look at P2Y12 inhibitors or other therapies and see how this score performs. There may be collaborations with other groups thinking about other populations and data sets. And one thing that we're thinking about specifically is that, you know, TRA2P TIMI 50 was a broad trial, not just post-MI. We spent all this time talking about the post-MI patient, but there were patients with peripheral artery disease too. They're very high risk, and we don't have scores to understand who's at the highest risk and who benefits from therapy, and that will also be an area where we do ongoing work.